Hey folks, this is Angela Cornelius and Matt Willens coming to you with another episode of Endocrine Knowledge. So kind of like we did last time, we're going to talk about a case, and then Matt and I will talk our way through the case and kind of explore what we think is going on from what we're seeing in this.
You are dispatched to a 50-year-old female with nausea and vomiting, along with altered mental status. On arrival, your patient is obtunded, responsive to painful stimuli, and seems confused when you attempt to speak to her. She is periodically vomiting, and her vital signs are a blood pressure of 102/81, pulse rate is 124, respiratory rate is 25 and deep, with a temperature of 97.6 degrees Fahrenheit. About 8 to 10 hours prior to your patient's presentation, the patient started to experience multiple episodes of nausea, along with non-bloody and non-bilious vomiting, leading to fatigue. The patient became altered about 2 hours prior to the 911 call. Prior to initiation of the symptoms, your patient expresses that she has had a suppressed appetite, which caused her to skip her dosage of metformin 500 milligrams because of a decreased oral intake and emesis. Past medical history of hypertension, diabetes mellitus type 2, and major depression disorders. She takes metformin, metoprolol, and fluoxetine. She is a former smoker with occasional alcohol use, but no drugs. She has had mild distress, tachycardia, tenderness around the epigastric area, and poor skin turgor.
So talk me through your differentials and what you think is going on with this current patient.
Okay, so again, like I told y'all last time, I really like a systematic approach, right? Start from the head and kind of work your way down. So let's start from the top down, right? We have an obtunded patient with vomiting. So obviously intracerebral process is high on my mind. Like, does she have a shunt? Is it malfunctioning? Does she have an intracerebral bleed? Or meningitis. Honestly, meningitis can cause a lot of these symptoms as well. And then let's move a little bit further down, right in the neck, hyperthyroidism, definitely there. She's tachycardic. So if you're thinking about cardiac and pulmonary, you've got to think about pulmonary embolism, right? Pulmonary embolism is always one of those things that can kind of act like a lot of other things. So it's on your differential for a lot of stuff.
Wouldn't she be more anxious with that too?
She could be. She could be for sure. But it's less likely in my mind with this particular presentation and history. And then moving down, right? So we have the abdomen. So she's got nausea and vomiting. Maybe it's just something like a bowel obstruction. Could be directly something like that. So looking at tachycardia and tachypnea and all the systemic symptoms that this patient's having, sepsis, right? Like sepsis, again, is a kind of an imitator like PE, and it can show up on lots of differentials. And then basic things like, is she just dehydrated? Are her electrolytes off because of dehydration and kidney failure? And then you've got to think DKA, HHS, even tox, right? Did she get into something and this is a toxicologic exposure?
So what would help you work through these differentials that you now have going through your head?
All right, so past medical history, right? Like if she had a history of head bleeds, do we know she has an aneurysm? Does she have a shunt? Did she have hydrocephalus as a child? Thyroid disorder, heart disorders, history of PE and DVT, diabetes. Has she had this before? Does she have a psychiatric history, right? You don't ever want to assume it's psychiatric, but it could be, and like that's definitely something to think about on your history. Does she use drugs? Is she a known drug user? Has she had any fever? Is she in a congregated living situation, right? Is she in a nursing home? Is she in a jail? Is she in a rehab where there's lots of people around to catch stuff from? What kind of surgeries has she had, right? Because that could lead to bowel obstructions. Any recent surgeries? So lots and lots of things are running through my head that might help kind of narrow this down for me.
So how does all that information help you come to your diagnosis?
Okay, so the information that we just saw, to me this is going to move dehydration with electrolyte abnormalities, DKA, HHS, and toxicologic ingestions up the list. Then it also adds something that I didn't mention before that's another endocrine thing, serotonin syndrome. Because she has SSRI usage, did she get another medication that just caused the serotonin to go crazy? So from your viewpoint, I get to ask some questions too. From your viewpoint, what information do we need to drill down on our differential, on the cause of this?
So glucose, your muscles, are they able to move? Are they stiff? Those are things that I would want to help drill down on some information.
Good. So this patient isn't presenting with rigidity, right? So she doesn't have muscle rigidity, and she doesn't have a high glucose. She does have a high glucose. So that makes me lean much more towards DKA, HHS, versus serotonin syndrome, which is kind of what the muscle rigidity would be referring to. And so DKA and HHS, right? They used to be treated as two separate things, but it actually looks like in the literature now that they're probably on a continuum with each other. But so let's talk about this, DKA and HHS, right? We know that there's significant overlap, but we know that in DKA, for some reason, those people get acidotic. And in HHS, they don't get acidotic. And so we haven't figured out exactly what the contributing factor is. We know that you have reduced insulin production in DKA, or inefficient insulin actions in HHS. So we know there are some differences there with as far as how insulin is either not there or it's just not effective. But we don't know what leads to that necessarily all the time. We know that both states have these counter-regulatory hormones, right? Because they're trying to fight, like your body's always trying to fix what's going on. So your cortisol goes up, your catecholamines go up, your glucagon goes up, your growth hormone goes up, and those are all trying to fix the metabolic abnormalities that are happening in your body.
Do you find that DKA has a lower sugar than the other?
Typically, yes. Typically, your HHS patients are going to be in the 800s to 1000s, versus your DKA patients might be as low as 300, 400. But so the differences between them, right? We know in DKA you've got way too much glucose, and the fatty acids that are linked to that have this pro-inflammatory state. And you have all of these interleukins, right? All these little mediators of inflammation. They're all really high, so it makes a bunch of cytokines, and cytokines are really very activating to the body. And so you get all these reactive oxygen species, and you get a bunch of damage from those to like your lipids, to your membranes, to your proteins in the cells. So we know a bunch of that happens, right? And we don't necessarily need to go into like all the super low level pathophysiology there, but, or I guess super high level in that case. But we know that if people are in DKA, that they have higher chance, or if they've had DKA, they have higher chance of acquiring chronic diabetes problems, right? And we know our chronic diabetes problems, poor circulation to the feet, neuropathy, kidney disease, et cetera. But in HHS, you have this absence of the ketone bodies. They think it's because there's a lot more insulin circulating in HHS. It's just not usable, if that makes sense. It's like defective insulin, or maybe the body's like hormone receptor for that is defective. But either way, that seems to be why the HHS people don't get as acidotic, which is interesting because the mortality of HHS is actually significantly higher than the mortality of DKA.
Is that because their sugars are higher when they first come in?
We don't know exactly. It seemed to me like logically that an acidotic person would have a potential for higher mortality, but it doesn't play out that way, and we're not exactly sure about that. But yeah, so it's very interesting, that kind of the two things. Now, for us, are we going to be able to measure if they have insulin that's just not working versus if they don't have insulin? Not really. At the end of the day, right, we're going to find a high sugar. So some things to think about when you're there is look for signs of infection, because almost always HHS is almost exclusively comes from an infectious source, from something, versus DKA can be infectious, but it can also be lack of medications, either medication noncompliance or out of medications or whatever it is.
So what signs and symptoms really pointed you more towards the DKA HSS for this person?
So for me, right, she's tachycardic, she's tachypnic, and the abdominal pain. Now, I know those are all pretty nonspecific, and you see that in a lot of symptoms, but you see that in a lot of patients who have DKA and HHS. The fact that her symptoms also developed over a pretty short period of time makes me think more DKA than HHS. HHS tends to be something that builds up over several days, whereas DKA tends to be a quicker process. It's more of over hours. So those are kind of the things that make me think along those lines. But I know the tachypnea, tachycardia, and abdominal pain are pretty nonspecific.
So can you make a distinction between DKA and HSS by glucose levels?
So not really, and we kind of talked about this earlier, but typically HHS is going to be really high glucose levels. Now, we don't have the ability to get down to the actual level of glucose, but I had an HHS patient that had a sugar of 1100 yesterday, and when we were in the hospital, we're able to figure that out, and so it was on my differential, like, oh, which is it? And once I got that 1100 sugar back, I went way more towards HHS, which is a slightly different treatment. It's much more of an emphasis on the fluids and less of an emphasis on the insulin.
So what causes these states?
So like we talked about, in DKA, medication noncompliance is going to be your big one. It's going to be about 80% roughly. But some other things, right? Infection, they can have a heart attack, right? And a heart attack can throw their body into stress, increase their cortisol levels, which is going to increase your sugars. So you can see how that can kind of roll downhill and lead to a DKA as well. Like a neurovascular accident, like a stroke, pretty significant stress on the body. Alcohol usage, and pancreatitis, right? These are some things that cause pretty significant inflammation in the body.
So we don't carry insulin with us for, we carry insulin for medically at home patients right now, but we don't carry insulin for the general population. So what can we do for these type of patients when we have them?
Right. So honestly, we have what they need most, which is IV fluid hydration. So a DKA patient, on average, is down 3 to 6 liters, but an HHS patient might be down 8 to 10 liters. And honestly, that's really the first thing we start doing well before we start an insulin drip in the hospital as well, is we start fluid hydrating in them. And that'll start reducing your acidosis and your DKA. That'll start correcting some of those things already. So we have what they really need already. We don't even necessarily need insulin immediately to treat this.
So you want us to start fluid boluses on them is really what
Fluid is important. These folks need fluids.
So to basically sum this up, DKA and HSS present pretty similar here with tachycardia, hypotension, signs of dehydration, and often altered mental status. But both cases they're both really dehydrated, and beginning fluids is really our key.
Absolutely.
In this.